Good afternoon. Good afternoon. We start the roundtable number 5, called the POP Repair, choosing the best option for our patients. Can you send me the first slide? I'm Mauro Cervini from Rome, from Italy, from Catholic University, and there is no? Okay. I have no disclosure. And I have a great faculty with outstanding speakers. Linda Brubaker, urogynecologist from United States, professor at University of California, San Diego. Paulo Palma, that is a female urologist from Brazil, associate professor of urology in Campinas University, Brazil, and Barry O'Reilly, professor at the Cork University, consultant of obstetric and gynecology. We have a brief overview, and then Paulo Palma will speak about the vaginal approach, where are we now. Then Linda will speak about abdominal approach, and Barry, hysterectomy or not at the time of POP surgery. Then we will present a clinical case, a discussion with all faculty. Which is the incidence of prevalence of POP surgery? By 2050, the number of women suffering from symptomatic POP prolapse in the United States will increase at minimum by 46 to 3.3 to 4.9 million, and in worst case, up to 200% more, 9.2 million women. And if you look at the fastest growing part of the population is the third in the geriatric population of elderly patients, you can imagine how much is the amount of patients, and the reason of why the institution, the scientific society, are so interested in this sense. Why? Because this are the long-term data about the surgical treatment of stress urinary incontinence, and we arrive actually about the literature 85 to 90%, while the surgical POP treatment, the overall outcome is 30 to 78%. And that means we have a lot of recurrence, a lot of problem in the surgical treatment of prolapse. Where is the location of POP urinary incontinence, of POP prolapse? Anterior anaplex, etc. But overall, the anterior compartment involved quite 80% of patients, and the highest failure is just in the anterior compartment, reported 30 to 70% of cases. Why? Because studies show clearly that patients with POP have altered collagen smooth muscle if you look at the normal versus prolapse patients. And that's the reason why it has been introduced since early 90s, the transvaginal mesh surgery. But in 2008 and 2010, the FDA, the American FDA, they report serious complications associated with PEP surgery, like erosion, pain, infection, bleeding, dyspareunia, perforation, and urinary problem. And there was a subsequent FDA warning in 2011 with the reclassification of the surgical mesh from class 2 to class 3 because they are not sufficient to provide reasonable assurance of safety and effectiveness for this device as a potential unreasonable risk of illness or injury. And these are the reports of the AUA last year in San Diego, 2016. The trends in POP surgery, you can see that the anterior and posterior has been declined, while there is a terrific increase in sacrocolpopexy and sacrospinal fixation. But there is a significant variation in the type of intervention undertaken because transvaginal mesh were used 8 times more in Germany, 26%, than in England, 3.3%, while sacral colpopexy 13 times more frequently in France, 66%, than in Sweden, 5%. And so such large variation explained by a variety of factors like women's preferences, cultural and demographic variables, access to healthcare professionals, health professional training, lack of clear consensus guidelines. So this is a lecture I did last March at the SUFO in the United States about the position of Mediterranean countries after the FDA warning compared the SUI and the POP. For the stress incontinence, there was no limitation on the use of the mid-urethral sling with the synthetic materials in the treatment of stress incontinence in any of the Mediterranean countries, and you know very well that the Scotland becomes the first country to suspend sales of transvaginal mesh as well as for stress incontinence. In Spain, there are key factors like the training of surgeons and majority of grade 3 or 4 for prolapse also was recommended for recurrent prolapse. In Greece, transvaginal mesh has definitely declined over the last 5 years, and mesh are still used for sacrocolpopexy, 1/3 to 3% of cases having transvaginal mesh for primary surgery, 8-10% for secondary surgery, and it will be very difficult to see in the short term a more wider use of mesh. In France, laparoscopy sacrocolpopexy is still the gold standard, but vaginal mesh are back with the new light propylene mesh. In Slovenia, mesh are used. Most mesh are used as a sling for SUI. For POP, they are used only for recurrent cases. In Israel, before the FDA warning, around 2,000 mesh kits were used annually. Currently, the vast majority is regular colporaphy, and most Israeli surgeons do not use mesh at all, and mesh procedure dropped to 300 to 500 annually. In Egypt, the mesh use on POP repair, the current practice is almost never used in public as a university, while in private practice, mesh only for recurrent or high-risk POP cases. In Italy, we have the proportion no less than 30%, but there is a trend toward the abdominal approach by laparoscopy or robotic surgery for the new approach of the POP. So the question is, which technique or which approach? We need to consider the age of the patient, the sexual and physical activity, the surgical contraindication, the risk factor, the body symptoms, and the expectation, because it's important to know what women want. And according to the age, young, menopausal, or elderly. And so we can have a different kind of modality in young women with uterine sparing in case of a fertility desire. In the postmenopausal with the multi-compartmental prolapse, we have a vaginal approach as well as sacrocolpopexy. In the elderly, obviously, the vaginal approach is the first indication with a native tissue reconstructive procedure plus or less hysterectomy and sacrospinal fixation. And in case of recurrence, the prosthesis utilized in vaginal as well in abdominal approach. I reported also the risk factor for POP recurrence, just the more recent papers published in the literature. This is in 2017. The POP stage 3 or higher is a significant risk factor for global recurrence. The premenopausal status indicates greater pelvic floor damage or poorer connective tissue quality. The obesity, the weight loss does not appear to be associated with the regression of POP, as well as macrosomia or lack of multi-compartmental repair. There is also a comparison between laparoscopy and robotic. There is certainly a significant reduction of voiding dysfunction with abdominal approach, a significant reduction on bothersome urinary symptoms. Considering the cost, because it is very important, and also the results, robotic versus laparoscopic sacrocolpopexy, equivalent surgical outcomes, conversion, transfusion, and complication were similar, and there is also a shortening learning curve, 10 cases versus 20 to 40 cases. Is robotic sacrocolpopexy cost-effective? The robotic has been shown to afford a cost saving over abdominal sacrocolpopexy. That depends on the case volume robotic institute. But also there is also a consideration comparing robotic with laparoscopy that obviously it's more expensive, but we need to calculate also the indirect cost like the adverse effects on surgeons or poor ergonomics, and also the expenses from the surgeon's standpoint, such as time off or decrease in case load. This is a question. Could we leave the patient without any kind of procedure? This is two very interesting papers. One is the natural risk of POP with the risk factors, that predictors of POP progression, like the baseline anatomy points BA more than 4 or GH more than 5, or the age over 60, and the progression of prolapse may not necessarily be indicative of worsening of symptoms that persisted in 30% of cases, improved in 60% of cases, and got worse in only 6% of cases. We know that sacrocolpopexy is the gold standard for the treatment of apical prolapse, level 1 evidence, and most durable. We know certainly that sacrocolpopexy compared to sacrospinal fixation, the length of the vagina is higher. The mean length in 12.9 versus 10.2. But we need to remind that the long-term outcomes following abdominal sacrocolpopexy for pelvic organ prolapse, they are less effective than desired because there is a decreasing of the outcomes in the long-term follow-up. Because we need to consider that prolapse is per se a degenerative pathology in a continuous and worsening evolution. So, in conclusion, where are we going? Significant decrease in transvaginal mesh placement, real indication for the posterior compartment, shift to laparoscopic robotic mesh sacrocolpopexy, and return to vaginal repair with native tissue. We heard by the other important speaker. Thank you.